morning. I'm Chiara Melloni from Duke University. I'm here with my colleague Joerg Herrmann from Mayo Clinic, and we're going to discuss thromboembolism in patients with cancer. So there are any new data? What are the main concerns in patients with cancer? Can you tell us about if there are higher risk of arterial thrombotic event? What is happening in these patients?
Yeah, I think one interesting development, and it came about with even the JACC trial a few years ago, that 1 in 10 patients in the cath lab actually have a cancer history. So it's not uncommon, even in the setting of an acute myocardial infarction, acute thromboembolic event. And we looked at this at our clinic in patients with STEMI and found the same data, that 10 to 12% actually have a history of cancer. And those who were diagnosed within the last 6 months of the malignancy even have the worst outcomes. And that's been shown not just in our series, but also in a European series. And it's very intriguing, very fascinating data. And not precisely clear as to why. And there are various challenges. These are sometimes considered more fragile patients, higher bleeding risks. And so there are some nuances then as it pertains particularly to the interventional management. We, as a group, an expert panel, released a consensus statement for SCI, the Society for Cardiovascular Angiography Interventions. And we thought that reasonable cutoffs to proceed an invasive approach to give aspirin would be a platelet count of at least 10,000. If you want to move on to stenting, you've got to have, and dual antiplatelet therapy, you've got to have a platelet count of at least 30,000. And if you're thinking about bypass surgery, you have to have a platelet count of at least 50,000, because those are some of the issues in patients with cancer. The other related to their bleeding risk is that you need to be very pristine in your techniques.
Yeah.
Radial access, Duke, I think you really like radial access too. It's something to do. And then the other is, if you take a femoral approach, really a small needle kit, ultrasound guidance would be ideal, because complications can be really, really devastating. And then the issue is, but we can talk about this a little bit more later maybe, is once the stent is in, what do you do? I mean, with a dual antiplatelet therapy, right?
Is that safe? Can they continue the same month as the other patient, general population, or what do you need to look for, what you're more concerned of during the double therapy treatment after the stenting?
Yeah, so the JACC trial again, as it rose to the front line, this whole issue about stenting in cancer patients was because they found that in their trial, the most common cause of death was actually non-cardiovascular mortality. That was the increase that was driving all-cause mortality, was not cardiovascular mortality. And among the non-cardiovascular mortality was cancer-related death. And when they looked further, interestingly enough, it was not bleeding. So bleeding didn't distinguish the groups between long-term or short-term dual antiplatelet therapy, and it was not higher in cancer patients. So a little bit of a conundrum there.
Yeah.
But nevertheless, it's felt that this is a high-risk group. I mean, intuitively, we feel as physicians they're at higher risk. And there are data to support this too. So there are some other developments as shortening now the time, as we've heard last week, for instance, exciting at TCT and reported also on ACC channels. The Twilight study. So Twilight was a large, over 7,000 patient trial. And those with high risk of bleeding and high risk of ischemic events. And they were randomized to 3 months of ticagrelor with aspirin, and then either go off aspirin, continue on ticagrelor, or not. And what they found was that it was safer in terms of bleeding events just to go on ticagrelor. And there, interestingly enough, I mean, that's not necessarily surprising, but no higher risk of ischemic events. So that might be something attractive moving forward for this group, because what we found in our analysis now of PCI patients with cancer, they not only have a higher bleeding risk, but they have a higher stent thrombosis risk. That brings me with thrombosis. that brings me to venous thrombosis, right? Interestingly enough, I mean, we've seen a little bit of a parallel that patients with cancer, right? I mean, even arterial thromboembolic events, they seem to peak early on, and then the risk goes down, and also the malignancies where we see this. So where do we see this for venous thromboembolic events?
So for venous thromboembolics, there are several data showing that the patient are higher risk, and usually the risk is higher in the first 6 months, in the really early months after cancer diagnosis, the time of cancer diagnosis, and the stage of the cancer is really one of the major predictor. In advanced stage cancer, patients are much higher risk of a thrombotic event, and also a specific type of cancer that are more prothrombotic than the other, like lung cancer, colorectal cancer, gastric cancer. They're the one where the patient are higher risk of venous thromboembolism.
Mm-hmm. And so, how do you screen for that? Do you risk assess? I mean, is there some preventive effort that should then be taken, or do we just wait and see?
The coronary risk score is used to stratify patient, and recently, just this year, 2 randomized clinical trials will be presenting, look at the prophylaxis of venous thromboembolism in the ambulatory setting. The Cassini trial had enrolled high-risk patient, high risk for a thrombotic event. They randomized over rivaroxaban and placebo. While the primary endpoint of symptomatic VTE were not significant, when they look at data on the pre-specified endpoint of patients who were on treatment, there was significant reduction in the events at the 6 months without really an increase in bleeding. So that was really reassuring. The AVERT trial enrolled patient, again, high-risk patient, risk stratified using the coronary risk score to apixaban or placebo, and the patient treated with apixaban had a significantly lower risk of event at 6 months. Mm-hmm. So the result of these 2 trials really led ASCO to update their guideline, and it's clearly that we should not treat upfront all patients, but we need to re-stratify them, and those who are at higher risk, if there is no really concern for bleeding or you do not expect any interaction, we know that the new oral anticoagulant may interact with many chemotherapy. If you do not expect an interaction, these new drugs can be used and are safe, can be safely used.
So the guidelines, I mean, are now updated?
Yeah.
And there are many guidelines, right? So which guidelines do we go by?
So the ASCO has recently updated their guideline, and I think we should follow.
We should follow the ASCO guidelines. And so this is for those we feel are at high risk, and we prophylactically treat them. What about those who develop the VTE event then? Cancer patients.
Yeah,
how do we treat them? Do we have any new guidance?
We have data as well. This last year, 2 trials, the Okusai VT cancer trial and the SELECT-D. They brought new data again on edoxaban and rivaroxaban, new data on the DOACs. They've shown they're safe. The Okusai VT cancer met the primary endpoint of non-inferiority when compared with the dalteparin, and SELECT-D showed that there was a significant reduction in recurrence of VT. There is a concern of some major increase in bleeding, and there are mostly also in GI patient with a GI cancer, genitourinary cancer. So we may want to watch out and be more careful on these patients. So we really need to be tailored on a specific cancer population. But I think the data are reassuring, and the guideline again, ISTH guideline has been updated to reflect that. ASCO guideline, again, they are consistent. The message is consistent, and recommendation are consistent that we can safely use these drugs in the cancer population.
By the way, so just maybe a final question is, so for the prophylaxis, then you mentioned the GI malignancies and the higher bleeding risk there. Does that pertain to the prophylaxis too? Would you be a little bit reserved giving it to those with GI malignancies then? Prophylactically up front? The door.
And I don't know this, yes, these are a population that I would be more cautious to prescribe them, but we don't have I think we will need more data, but really will be more comfortable in other cancers, I think.
And who knows that after all, now with the COMPASS trial, showing some benefit of the combo of
Yeah,
rivaroxaban, right, a lower dose, but an aspirin for ischemic events. Who knows? Maybe for the cancer patient,
we don't
that
know.
will be
There's
the
some patient that
one-shot
maybe,
fall.
we can look at reduced dose. We can really taper therapy for them.
Wonderful. So that's it for us from our update on thromboembolism, right?
Yeah.
From this meeting, and so likely more to come and more to read in JACC Cardio-Oncology.